Good afternoon, good evening, or good morning, depending where you are in the world. I'd like to welcome all of you to the 24th Annual Douglas West Memorial Lecture and the first Douglas West Memorial Virtual Lecture. Thank you all for joining us tonight. My name is Sean Morrison, and I have the privilege of being the chair of the Brookdale Department of Geriatrics and Palliative Medicine and the Hertzberg Palliative Care Institute. I want to just start this evening by thanking Susie West for endowing this lecture in memory of her husband, Doug, and in honor of his physician, Dr. Diane Meyer. When Diane cared for Doug, palliative care was a new and emerging field in healthcare. The Lillian and Benjamin Hertzberg Palliative Care Institute did not yet exist at Mount Sinai, and there were only 3 palliative care programs in academic medical centers in the entire United States. A quarter of a century later, every academic medical center in the US has a palliative care program. Departments and divisions of palliative care exist in nearly every medical school. And most importantly, Americans have access to palliative care in over 3/4 of the nation's hospitals. Over the past year, as the nation faced the greatest public health crisis in its history, this widespread availability of palliative care ensured that tens of thousands of patients hospitalized with COVID received world-class treatment of their symptoms, breathlessness, anxiety, delirium, and that their families were supported and cared for. Within the Mount Sinai Health System, although patients were isolated, and visitors were barred from our floors, our patients were never alone, thanks to the efforts of our extraordinary faculty and staff. The integration of the Brookdale's department's teams into every key hospital setting, the emergency department, the intensive care units, and the COVID floors ensured that every patient with severe COVID received the added layer of support that our teams regularly provide. As importantly, however, the partnership with emergency, critical care, and hospital physicians ensured that while we were attending to patient symptoms, Zooming with families, or coordinating care, our colleagues could see and evaluate the next patient newly arrived in the ED, manage the ventilator setting of others in the ICU, or move to stabilize the next hospital admissions. Thousands of patients were comforted. Hundreds of lives were saved. Many are responsible for our health system's response to COVID. Yet it is really safe to say that this would not have occurred without the work of 2 women who, as of this month, assumed emeriti positions. Susie West, who stepped down from her role as the Hertzberg Palliative Care Institute Advisory Board co-chair and the sponsor of this lecture, and Diane Meyer, who stepped down from her role as CAPC's director. Without Susie's philanthropy, her vision for what the Hertzberg Institute should be, and her persistence in engaging others to share her vision, we simply would not have had the resources nor the ability to make the impact that we did over the past year. Thank you, Susie, and thank you for having this lecture virtual this year, because you would have pulled me off the stage if I had said that in the regular setting. Diane, it is hard to put into words what your leadership has done for the field, and even harder to imagine what the field of palliative care would look like without CAPC. Simply put, most of us would not be here, and most palliative care programs in this country would not exist had you chosen to continue on your original path of being a bone disease physician. Thank you, Susie, and thank you, Diane, for your extraordinary contributions. I also speak for many when I say that I am very much looking forward to what challenges you both will be tackling next. It now gives me great pleasure to introduce one of medicine's true rock stars and a hero of mine, Louise Aronson. Masterful clinician, best-selling writer, journalist, teacher, and leader are just a few of the titles Dr. Aronson carries. Officially, she is professor of medicine at the University of California at San Francisco. Her most recent book, Elderhood, Redefining Aging, Transforming Medicine, Reimagining Life, was a finalist for this year's I'm a year ahead, 2020, for the 2020 Pulitzer Prize for General Nonfiction, and has been a bestseller on our hometown newspaper's bestseller list, the New York Times. She's received a McDowell Fellowship, 4 Pushcart nominations, the American Geriatric Society's Clinician Teacher of the Year Award, and a gold professorship for humanism in medicine. She personifies the words Renaissance woman. Following her presentation today, I'm delighted to say that she'll be answering your questions. So please feel free to submit them through the presentation by clicking the Q&A button at the bottom of your screen. And without further ado, let me turn the evening over to Dr. Aronson. Louise, thank you for joining us tonight.
Well, thank you for having me. It's an honor to be here, although I'm in my usual chair, but many of you may be in the same situation. Anyway, thank you for the introduction, Sean, and thank you to the West family for this opportunity. And I just agree with everything you said about Diane and can't think of anything to add to that. So I thought about the way this lecture is usually given with a person speaking, and if I could see you all and be with you, that's how I would do it. But I feel that it's kind of hard to listen to a talking head for over, I don't know, 10 minutes or so. So I'm going to use some slides in hopes of providing a little bit of entertainment as we go here. So I'm going to start with the cheerful topic of death and old age in hopes of convincing you by the end that there's a lot to be cheerful about and that we are really, I believe, on the cusp of a new age for old age. So I like this Peanuts cartoon. Charlie Brown says, "We only live once, Snoopy." And Snoopy, I actually have a beagle, full disclosure, but he says, "Wrong, we only die once, we live every day." And I kind of like the intersection of geriatrics and palliative care for encompassing all of this. And obviously we all do some of both. But I'm going to focus a little more on how we live and the ways we can make our lives better as we become older. As Sean mentioned, this year we learned a lot of things. It was a hard year for most people in many ways, but among the things that we learned was that age matters. Now, for many of us, we already knew that to be true. And I think people look at this and it often just fulfills their every prejudice about old age. So among the things I have been virtually going around the country trying to show people is the many ways in which biology has been just one component of this extraordinarily horrifying death rate, with people age 85 and above having a 7,900-fold risk of dying from COVID over a 17-year-old. We also learned that age wasn't everything. Now, we already knew this, but it finally began to get some of the attention that it needed. So to take but one of many, many examples and remaining focused on COVID here, these are mortality differences by race, ethnicity for people ages 75 to 84 compared to non-Hispanic whites. So Blacks had a nearly 900-fold increase in risk, Latinx over 500, Native populations 200, Asian and Pacific Islanders, lumping a diverse group, but about 150%. So yes, old age is a risk factor, but it's not the only risk factor. And the fact that race plays such a huge role in the risk for older people shows us the degree to which mortality from COVID, and by extension, mortality generally, has as much to do with social factors as it does with biological ones in many situations. We saw here that COVID really had a predilection for older people. And at the same time, Yes, you were more likely to die if you were older, but we're also always more likely to die as we get older. So, how do we sort this all out? Because we also learned some other things about old age in 2021. If you look at who is running our country right now, we have a 78-year-old president, a 71-year-old at the head of the Senate, an 80-year-old at the head of the House of Representatives, and then we have our own medical rock star, age 80. So we're getting a lot of mixed messages, and that's part of the problem. The other part of the problem is that people seem able to hear certain messages more than others. So I think it's good to begin this discussion of aging by thinking about what old age is. So often when we hear people talk about old age, they think of it basically as something older than what they are, right? So this is the cover of a book from a few decades ago, and just says old age is always 15 years older than I am. And by that they always mean it's somebody else. We all seem to have a 15 or 35-year-old inside us throughout our lives. Those of you who, like me, take care of patients will hear this from a majority of them, that they just can't believe it when they look in the mirror or they try and do something. But we actually do have some pretty good data, both biological and historical, about when old age starts. Biologically, you could do worse than to look at some of those COVID curves, where the risk begins going up in middle age and climbs precipitously after age 60. If you really are speak to people and have them be honest about what's changed with their bodies, that is often the case. And indeed, the Pew Research Center did a telephone survey a few years ago, and they found a couple of things. One is that the historical touch points of old age beginning between the ages of 60 and 70 in most cases, and 75 being the highest legal old age that we've encountered throughout cultures and history. People agreed on that span, but depending on how old you were, you thought old age started at different places. So younger people think old age starts at a younger age, and older people think it starts at an older age. So the eye of the beholder is here. We also know from accelerated aging that there are people who are very old if they have been homeless. They can seem quite old in their 50s or 60s, and other people who've been more fortunate that are incredibly fit in their late 70s and 80s. But the eye of the beholder problem is shown by this data from the same survey, where men and women, and apologies for being binary, that was the study, were asked what age a man becomes old, and everybody agreed that it was at age 70. But when asked at what age a woman became old, men thought it was 68 and women thought it was 75. So what old is depends on how we define old. Is it what you look like, what you act like? Is it something intrinsic? This economist at Stanford called John Chauvin decided that it was your chance of dying, and went back through history and found that this held pretty steadily with behaviors associated with being middle age, where you also seem to have a 1% chance of annual mortality, being old, where you had a 2% chance, and being elderly, where you had a 4% chance. And then he found that that all those age groups had increased by decades over the 20th century. Now, this isn't surprising. We know longevity was extended in that period. And yet, what have we done with it? Well, a few things. Prior to the pandemic, people in their 70s were the fastest growing segment of the American workforce. And we all do things now at older ages that were simply not culturally acceptable 100 years ago. But some of how we think of age actually does us and our society and those of us who care for people who are old or grievously ill a great deal of harm. The fact is, we all have to die. The best case is to die in old age with really good care, as comfortable as you can. And at the same time as John Chauvin was showing that we were dying, that old age was becoming older, we were still dying in old age. So part of this is a biological reality. and part of it is not. So where are we now, and how does how we think about old age determine our experience of it? Given the convenient proximity of the pandemic, I'm going to sort of show how the things that we've all gotten used to can do us harm and how they manifest during the pandemic. So these are some of the stories we like to tell about old age, and some of you will be familiar with these from the frameworks work and other such things. There is the exceptional elder. The newspapers are especially fond of these stories. The problem is that exceptional people are exceptional, right? So some of us were never going to be a model, and it didn't matter what age we were. So this man on the left is an older model, but some people are born with a face and body to do that, and some of us aren't. Similarly, this woman is doing the splits in a way that would have made me require orthopedic surgery even if I was 8 years old. So exceptional is exceptional. Now, we know from the work of Susan Friedman and others that usual aging is impacted by all kinds of choices and environmental things. So maybe all of us could be a little more exceptional than we think we are in some ways, but holding up an exception leads us to look at most people as failures. And when we do that, what do we get? We get the silver tsunami. There is no upside to tsunami. Notice how the older people are sort of monochromatic. They are painted with a single swath. They're colorless. Color usually denotes cheer and diversity. So it is technically inaccurate because we know some of the greatest diversity among human beings comes in the older ages. It also sort of pits the people we purport to care most about, our children, against the older generations. So it's inaccurate and it's dangerous. And it's really popular. It's a shame it's so catchy because I don't know about you, but the first time I heard Silver Tsunami, I thought, oh, that's so smart, until I really thought about it. But when you have the Silver Tsunami language and when you have exceptional elders and most people failing to live up to that standard, you end up with things like boomer removers, right? Because if you have a huge tidal wave of, useless people coming at you, maybe it's a good thing if a virus removes those people. On the other hand, some people argued that boomer remover was a joke. And so that kind of speaks to aging and the generations as well, because maybe the sense of humor had changed. So either way, you think here are people not respecting or understanding or having compassion for older people, or you think we have a generational disconnect in humor, and that's going to make it hard to make a case for each generation listening carefully to the others. This was a headline in Time magazine last year. It said, "The Road to Recovery, How Targeted Lockdowns for Seniors Can Help the US Reopen." And I want to just remind you of the tidal wave again, because if you think of the US as also the words us, it's seniors versus us. We can help us, those of us who count, by locking up old people who, of course, don't count. Even though we had many presidential candidates in the so-called seniors realm. So there is a way in which people cannot see what's right in front of them, and they tell a single story about old age, a harmful one. This was from an ethicist, profiled actually in last week's New Yorker, asking whether age discrimination is acceptable. There was some irony here because the day this was published, June 10th, was the time of George Floyd's funeral, a time when we were finally beginning to reckon as a nation with our racial discrimination, belatedly and not as effectively as many would like, but at least we were tackling that. And in that same moment, there was a question of whether a different sort of discrimination was really okay and better for us as individuals and as a society. that makes it hard for people to hear honest and real stories. So this is the work of Blanche Flower and others. And there was a review last year that looked at all the studies of the U-shaped curve of happiness, which is what this is called. We're happiest in youth and in old age. And indeed, there are other benefits. We become less anxious as we age, and we have higher life satisfaction. I do apologize for those of us in our 40s and 50s who are at the nadir here. But the review last year really showed that although this does not hold everywhere, it does not hold for the most disenfranchised in a given population or countries that are themselves gravely impoverished. Take Mali, for example. But it does hold otherwise, and yet people have trouble hearing this. They listen to one kind of statistic and ignore others. That also means that we keep hearing the negative effects of lockdowns and pandemic on older adults. And that's true, but it's only part of the story. This was an editorial in JAMA summarizing 8 months of trials, showing that actually older adults might be less negatively affected. And we've just seen more and more data on that. Now, again, does it matter how isolated you were? The data shows that there is huge diversity in old age. People in the community doing better than people who are in long-term care facilities, who are truly locked in a single room for over a year in some states, including my own. People who have fewer social connections, who have histories of anxiety and depression, more likely to be adversely affected. But the vast majority of older adults doing better than younger adults, doing better than many school-age children. And this was discussed in one of my favorite medical journals, the New York Times, just recently, where a psychologist reviewed the data longstanding from the psychology literature. And I actually think we could do a better job with aging and with serious care if we included more of this literature into our work. But he talked about how people age 50 and older consistently score higher in having more positive emotions in a day and fewer negative ones. And that was independent of income, education, and some of the other confounders that we often think about. So why don't we hear these stories more? Why don't we hear more about the diversity? Why don't we hear more about the resilience and the adaptability? And the ways that the pleasures of old age may be chosen from a narrower menu of options, but are enjoyed so much more. Part of it may have to do with what the British philosopher John Berger called our ways of seeing. To take, for example, this painting on the right, as a person who's been locked up for over a year now, spousal vaccination in progress, thank goodness. Anyway, so I think, oh, wow, to be in nature, you know, birds flying, beautiful colors everywhere, maybe springing. Isn't that lovely? And you may see that too, but then if I tell you this was his last painting before he committed suicide, you might see those darker slashes in a different way. You might see the path, which could be a beautiful meandering path for a country walk, as a path to eternity or a path to nowhere. And you might see those birds in a very different light. Similarly, sometimes when we look at old age, we see a person alone. We see a person bent over. We wonder, those of us who are clinicians in this case, about osteoporosis, we wonder how much she shrunk. We begin to see diagnoses. But if I tell you that for this particular photograph, I cut out some important factors. I cut out busy streets, and I cut out a security detail, because this was actually Ruth Bader Ginsburg walking to work. And maybe she was thinking about the opinion she was going to write that day. So what we're told, what the context is for information, matters a lot in how we process it and receive it and see it. So death, you know, we think of death, people who lived in nursing homes, they were really old and really frail, so of course they died. But if you look at this chart on the left, it shows a fourfold difference in nursing home death rates between Minnesota and Rhode Island compared to Nevada and New York. Is there any biologically conceivable reason why people in Minnesota would be 4 times more likely to die than those in New York? And this shows you the degree to which social factors and policy factors influence our risk of death and whether our deaths are counted. We know many deaths were not counted in the first surge that you all had so gravely. And we also know that each state's ability to count deaths varies tremendously, and what data they submit varies tremendously. So social factors critical to whether you die and also whether your death is counted. We saw earlier about the racial disparities in terms of death in older community dwelling people. So it's not just about old age, it's about so much more. But some of the message we give about old age lead people to believe that it's hopeless and there's nothing we can do about it. So this is from the city of Boston's anti-ageism campaign, and it did some wonderful work. But I also disagree with some of its key points. So here we have this gorgeous woman, age 86, and she says, I'm a lot of things, but over the hill isn't one of them. Well, if you think of life as a narrative arc, right? The hero goes on the story and there's sort of the climax and then the downfall. Or if you think about it, if you're more mathematical or scientific as a bell-shaped curve, then over the hill is, and if you even just look geographically at most hills, over the hill is the second half of life. So does this mean that as of age, depending on who we are and where we live, 30, 35, 40, our lives no longer count? When you have someone saying, I'm not over the hill, when they're 86 years old, what it does, instead of saying like, not, the intent was to say not all old people are of no use. So there are two problems with that. It reaffirms the notion that being over the hill equates with being of no use, which leads to a world in which it's fine to let people die in nursing homes and to lock up older people in our communities. And it says that people who are less functional are less worthy, that their lives don't matter to us. So those are two messages that I would not want to be putting out into the world. When we do it also, we create a world in which older people aren't really seen, even when they are the most impacted. So this is the CDC, public-facing webpage about things you need to know and do for COVID. And you'll see that they have a pull-out menu with the little plus there for children and teens. And then there's a 9-item pull-down menu. So that's terrific. But we saw earlier that children and teens were at really, really low risk for getting COVID and for dying from COVID. This in contrast to older people. So you might think there'd be a pull-down menu for older people, but when I look and I look and I squint and I can't see it, and if you look a little harder, you will find them under people at increased risk. So the increased risk is such that 80% of deaths are in old people, although they represent 17% of our national population. And they're not actually on this list. So in December, they had older adults as a page, and they were basically divided into people with certain medical conditions or people who need extra precautions, because they're not seen by our health and public health systems as a category unto themselves. Indeed, this continues now. Look at the current pull-down menu, which has older adults, but again, there is no plus sign next to older adults. There's a single page. If you have multiple medical conditions, there's pull down. If you have alcohol, drugs, or substance abuse, there's pull down. If you have developmental disabilities, there's a pull down. So the people at highest risk are lumped with people at also high risk, but not in a way that accords to the actual risk different groups are suffering. So by the very structure of the web page, there is ageism, and there are mistaken messages about what people can do, how people can be diagnosed, what the risks are for different categories of human beings. That matters because, as this writer, Ursula Le Guin, said, to tell me my old age doesn't exist is to tell me I don't exist. So when people deny their age, when they say they're not over the hill, instead of this is one of the many ways over the hill looks like, their true needs are denied as well, such as the very different presentations of COVID that we have seen, which are exactly analogous to the very different presentations of everything else that we see as geriatricians. This is one of my favorite quotes ever. So Ursula Le Guin said, "If I'm 90 and believe I'm 45, I'm headed for a very bad time trying to get out of the bathtub." So our age does matter. And it might mean it's harder to get out of the bathtub. That doesn't mean you don't have any value as a human being. Bob Butler won the Pulitzer Prize for this book in 1975, Why Survive Being Old in America? And what he said, and we've just seen that this remains true, although again, we are at a tipping point. The tragedy of old age is not the fact that each of us must grow old and die, but that the process of doing so has been made unnecessarily and at times excruciatingly painful, humiliating, debilitating, and isolating. So if your risk, your age group's risk for death is 80% and you're not even listed on the website, that tells you how much you matter. And if you have different presentations of the illness that is causing a global pandemic, and those presentations are not listed by the Centers for Disease Control website, that sends you a message that is painful, humiliating, and isolating, especially when people in other categories, in other age categories, especially when the system recognizes age categories and puts up special presentations for children. And it's not that we don't want to pay attention to children, it's that we want to pay attention to everyone. So how do we begin to rethink old age? And why might this be the moment? Well, this might be the moment, not because old age is changing in any significant way, but because now most of us have decades in old age, if indeed it starts at age 60 or 70. And because having more people in old age leads to a need to restructure society. So I obviously have a bias about this. I believe we have three major parts of the lifespan. There is childhood, there is adulthood, and there is elderhood. And within each one is a huge range of different social behaviors, immunologic strength or weakness of biology. So you begin as a neonate and you end as a teen or young adult. Then another minute you're a young adult and then you're middle-aged, and those are so different, but so too are the 65-year-old and 95-year-old. They are no less different. And it's time we recognize that. Now, if we didn't have a system that already divided us by age, it might be adding complexity to add this in here, but we actually have a healthcare system and a society that is very much divided by age, only it neglects the third part of our life cycle. When we do that, we end up without language or policies for people for decades of life. If you Google the human lifespan, you often find a chart like this, which shows infants, toddlers, kids, and teens to represent childhood. It shows young adults, adults of different age, in different decades and phases of life, and middle-aged adults next. So another four categories. And then it makes a huge leap from the phase of being in your 50s or 60s, where maybe postmenopausally your hips get a little wider, or maybe it was COVID, and you might need bifocals to read. And then we jump from there to a wheelchair. Now, there's nothing wrong with being in a wheelchair, but almost none of us goes from middle age to wheelchair. It's an inaccurate representation of the human life cycle. It's leaving out decades and multiple transitions. And we don't even have a language for this. So is it any wonder that we don't have policies when we can't agree on even something so basic as terminology, when we don't distinguish old at age 68 from old at 78, 88, 98, or 108? There are some very large groups thinking about this, and I like the idea of thinking about the World Health Organization map for this because, like geriatrics and palliative care, it looks at the larger system, not just at our bodies and health. And also because after another huge global crisis, the WHO was founded. And I'm wondering what sort of huge organizations or cultural shifts we might evince in the wake of the COVID pandemic. So they talk about healthy aging as being able to do the things we value for as long as possible, recognizing that both who we are and what we can do and what we value may change over time. So we don't really have a healthy aging perspective. When we think of aging strictly as disability, that is not a healthy aging perspective. And it's not a perspective on the decades of elderhood that is analogous to the perspective we hold for childhood and adulthood. So how do we look at this? I'm actually going to go backwards because if you go forwards, you end with long-term care. And frankly, after the last year and some, or maybe the last few decades, that's not a happy place to end. So in February 2020, we learned the first outbreak of COVID in the United States was in a nursing home. This shouldn't have surprised anybody, seeing the massive numbers of deaths in old age in China, in Iran, in Spain, in Italy. We knew it was coming. We didn't prepare for it. It happened. But we also didn't prepare for it because we don't do much to make nursing homes safe and comfortable for people. And so 14 months later, nearly 1/3 of deaths are in nursing homes, even though 4% of cases are in nursing homes and fewer than 2% of older people and a much tinier percent of people generally live in nursing homes. We'll come back to why this was and how it had as much to do with social engineering and policies as it did with being vulnerable and old. And so one way in which this happened, and this is from New York Magazine, this article looked back at the history of being old in America. And what it concluded was the horrific totals were not inevitable. The virus is an efficient killer, but it had accomplices. So it talks about how the governors of New York and New Jersey decided to discharge people from hospitals to nursing homes with COVID, and how this probably accounted for at least 9,000 excess deaths in the first surge, the spring of last year. So it took people who were at higher risk for severe illness and transferred them out of hospitals where you get better care. And it took them with their virus in order to free up beds for us, right, for younger, sicker people. It put them in nursing homes where the staffing ratios are less good, where the care is less good, appropriate to station, but not as good as a hospital, and where they then infected other people. I will also say that in San Francisco, at some point, it began listing that our health system had 100% PPE, meaning 30 days of PPE in all healthcare settings. That did not include nursing homes. So one of the things we need to think about is, are nursing homes part of the healthcare setting or are they not? This is often what people think of, and too often what happens in the long-term care setting in this country and elsewhere. And it makes me think of this quote by James Baldwin, which was referring to Black lives in America, not to older lives, but I think it holds in all kinds of ways. And it also is worth noting that if you were Black in a nursing home, even if you accounted for income, health insurance, comorbidities, etc., you were much more likely to die. So what James Baldwin said was, people who treat other people as less than human must not be surprised when the bread they have cast on the waters comes floating back to them, poisoned. So we allow this to happen. We create our own futures we dread, and that make everyone scared of growing older or going into a nursing facility. All right, so now how do we make things better other than overhauling our entire long-term care system, which requires a little more time than I have right now? We need to align the health systems to the needs of older people. We currently have rotations that are basically the same as the ones my father did in 1955 when he went to medical school, where there were a lot more kids and a lot fewer older people. Now you can see the population pyramid is turning into a rectangle. And yet, in medical training, we still hear about children and adults. We still hear about the 70-kilogram man, and we know if we're not getting him, if the person is pregnant or has sickle cell disease or has AIDS. We have these same rotations that prioritize things like delivering babies, as Roseanne Leipzig said famously in the New York Times, even though fewer than 3% of us will ever do that again, but don't prioritize the older people that are 35 or more percent of hospital admissions. And it makes you wonder, yes, we're more likely to die the older we get, but are some of those deaths because of over and under treatment? Are not a huge proportion of those deaths because the NIH did not require older people to be part of studies on procedures and drugs that would be applied to them? It passed mandates for the inclusion of women and minorities in the 80s and for the inclusion of children in the 90s, but did not mandate the inclusion of older people until 2019. And so might it be that, yes, we do die in old age, and yes, our medical training and healthcare systems are part of the problem and part of why and how people die. We in geriatrics have to recognize that we too are part of the problem. We have said for so long that there are few of us, so we're going to focus on the oldest and frailest, and then we complain when we're left off the table, right? When even pediatrics gets several months in the medical school curriculum and the nursing curriculum. When we focus only on the oldest and frailest, we suggest that that is old age. And that goes against everything we know as a society in terms of social behaviors, in terms of biology. Everything that was proven time again with COVID, where the death rates really started to climb for people in their 60s. We're maybe providing really good medical care for people who are very old and very frail, but are we providing health care for people throughout all the substages of elderhood? And are we looking at elderhood and teaching elderhood in a way that people who are interested in tech or health might be interested in geriatrics and in keeping people healthier longer? When we don't do that, we get things like the CDC vaccine schedule, which acknowledges the biologic, immunologic, and social differences of children with 17 subcategories, of adults with 3, and yet lumps everybody age 65 and up for that half century of human life into a single biologic, social, and immunologic category. In teaching only the oldest and the frailest, we suggest that's everything there is to know about those decades of life. It's not true. Indeed, we have had data for many years. This was just one convenient chart that I had in my older files showing how the different decades of old age are different. We need to be teaching this more, and we need to be thinking how we support the care of people in different phases of elderhood, not just at the very end. We need to, every time people are talking about kids and adults, ask them, what about elders? And whenever we're having pediatric and adult hospitals, ask, what about geriatric hospitals? And do I know that we need geriatric hospitals? Do we know that that's the best approach? I don't. I know that nursing homes aren't geriatric hospitals, and they're not the solution. And having one size fits all adult hospitals aren't either. So creation of age-friendly environments. This is obviously a huge topic, and there's so many ways in which it can be done. But I think we won't get age-friendly health systems that are more ambitious than medications, mentation, mobility, and what matters, that we get ones that are equivalent to the ones that already exist for childhood and adulthood, until we begin to have communities that think about all aspects of human lives in age-friendly ways. There are examples from doorknobs that are easier for people to turn and that should be ubiquitous. Why do we even have these ones, these other ones? I mean, didn't you love in COVID how you could use your elbow and keep your hand clean? It's better for all of us. We could have bathrooms where a person could age in place instead of wondering how to get into or out of this tub. And moreover, the person can't shower either because that's so hard to get into. And how are they going to get up from the toilet? And no, it doesn't have to be ugly just because it's for an older person. We could have parks where people of all ages could play and exercise, not just people who can run on a basketball court or soccer field or who want to play on swings, but people who want to play pickleball or do some Tai Chi. And we would have a health system that focused not on anti-aging medicine, but showed that there is an evidence-based way of doing that that isn't anti-aging, but pro-aging, that put geroscience as an exciting field that people should want to go into if they want to be on the cutting edge of medical science today, where we extend the health years so that they are more commensurate with our longevity. We would acknowledge, we would be part of the measures to make our healthcare system anti-racist, because as we saw, the racial inequities survive into old age, even when most people of color don't. That says a lot. And finally, we need to change the way we think about aging and older people. That starts with not denying frailty. Not having somebody who's 83 say, hey, I'm not frail, because we all know he will be soon, barring a sudden death. And he's helping create a world in which it won't be okay to be him in a few years. That's so counterproductive. We can all do better. Indeed, I would like to push back against some of the work of JAGS and other journals saying we should only use the words older adult. When we only use the words older adult, we pander to the very ageism we're threatening to combat. The words like aged, elder, elderly, and seniors only mean a human being who has lived longer. We can call a person's child a tween or a kid or a teen and they don't feel insulted. I can call my students younger adults or young adults and they don't feel insulted. I'm an older adult. My mother, 30 years my senior, is old. She is in fact elderly at this point. We need to live, we are not going to have a world in which it's okay to be those ages, in which you can thrive at those ages if we can't even use the words that connote them. We also know that internalized ageism kills. So we need to be addressing this with our patients and with ourselves. It kills in feeling like there's nothing you can do to make your life better. That there's no point in doing health behaviors, and it kills because it elevates our levels of cortisol, which leads to stress and premature aging. Whereas positive stereotypes increase our recovery from problems and illnesses and increase our longevity. I just want to do a shout out to Sharon Inouye's recent article in Nature Aging about anti-ageist healthcare. I think this and the article by, oh no, my brain. It will come back to me. Pandit in JAGS recently talking about the future of geriatrics are this broader, different lens where we and older adults stand up for what matters in older lives, just as people already do for younger lives. This is from San Francisco's anti-ageism campaign, and you see the same people in old age where their eyes are, and in their younger years where their foreheads and mouths are. And it's to remind us all that in everybody who's an adult is an elder in training, as Joanne Lynn would say, and in every elder is an adult who matters. So I'll just leave you with the thought that what if the greatest limitations of aging come from our imaginations and policies, not our physiology? And what if we could make those years Snoopy talked about, the years of living prior to our deaths, better and healthier by confronting the ageism that surrounds us? And with that, I will stop and I'd be happy to take any questions.
Wow. Thank you, Louise, for a really phenomenal talk, which has given all of us a lot to think about. I know there's a number of questions in the Q&A, but I wanted to start with one that's your advice, which is, I was thrilled to see you quote Bob Butler, who was a mentor of mine and founding chair of this department. And yet, Why Survive was written nearly 50 years ago. And so much of that book could have been written today. And much of what he outlined is very similar to what you were talking about in some respects. And I guess my question is, what realistically and pragmatically can we do now to get to a society that recognizes who its population is, both in terms of healthcare, so that medical students don't learn that a 35-year-old kidney is a normal kidney. A normal kidney is probably a 75-year-old kidney.
Yeah, a white
And,
heterosexual male kidney. You forgot all the other, right? Yes, that's 35.
And that,
we're all part of the same thing here.
And that our infrastructure is designed to support the people who need it rather than the majority. And I wondered if you had some really sort of pragmatic, practical steps about what we can do in that regard.
Yeah, I think there's several things. One is, I think we who do geriatrics should take a field of dreams approach, build it and they will come. We need to make it much bigger. We're always happy to get some time in the curriculum and to discuss, delirium and dementia. And I think we need to say, let's look at the numbers. So we also do it with an evidence-based approach. We don't, when people are making decisions, whether it's about how to put different, services in a hospital building or how to populate a curriculum, they claim to be okay, so sometimes they're thinking about money, admittedly. So that needs to be addressed. But I also think we need to address unmet needs and practice evidence-based medicine. So if you show the evidence about who is in the hospital and who is using healthcare, and then you show the evidence that they are already doing an age-based approach, then you say, we need to restructure this. This is all out of date. This makes no sense. And the building of new hospitals offers an opportunity to do this transformation. I think we also market ourselves differently, and that's where the Pandit article talked about direct to consumer marketing. And I think that's a different framing of it than I was thinking. But as boomers are becoming part of elderhood, that's a generation that actually Rich Eisenberg, who publishes Next Avenue, which does a lot of great journalism about aging, he said at a panel where we were together, he said, we used to think boomers were all about youth, but it turns out we're all about ourselves, and now we're old, so look out. And I kind of like that in contrast to the silent generation. I think it's about, people like Nancy Pelosi or Joe Biden saying, I'm old. And here is what people of my generation need. And people not denying so much their age, but saying, hey, look, COVID showed, and we need to respond to this. So it's about owning old age. It's about evidence-based medicine and giving people the evidence. It's about demanding equity when we're thinking about different terms of equity, also adding health equity. And it's about framing, I guess, using Kelly Flood and others, framing of the financial arguments for older adult care and not limiting it to just frailty and long-term care. I have had pushback in my own division from that perspective saying, but what about those people? well, all of us who love taking care of those people will still be there. But there will be so many others who are also so excited by geroscience or so excited by healthy aging, and sometimes go to the dark side of, of for-profit because there's no room for them in standard evidence-based, medicine with a good conscience. We need to make room for all of that. And the bigger it is, then you've got another kind of financial model that people will respond to.
Thank you. From our Q&A, one of the things we learn as medical students is to note whether a patient appears their stated age as an indicator of health. There are so many other examples of ageism in medical education. What advice do you have for students and trainees to actively avoid developing age-related bias while in our training?
Such a nice question. Thank you, Emily. Yeah, it's an interesting thing, appears their stated age, which usually if you're old means you look old to me. And then the compliment is you look younger than your stated age. But Gloria Steinem had a good response to that, was like, hey, this is one of the ways 80 looks. This is what 80 looks like. Now, 80 for her isn't even like 50 for me. So, there's variety. I think, just maybe in the ways we're getting rid of racial markers, we stop doing things like that. And we also start just listing the age in a neutral way, because it is one of the many factors that's relevant. But then thinking about the other things we think about in geriatrics, including functional status and health status, and really painting a picture of that person as a unique individual. That makes a huge difference.
I am told that Diane Meyer, who this lecture in his honor, has her hand raised. So wondering, Katie, if you could bring her in and she can ask what her question.
Hi, Louise.
Hi, Diane.
How are you? So nice to see you. Thank you for joining us and giving such a inspiring and moving talk. It energized me. I'm wondering what you think about, you point out that medical education is stuck back roughly 100 years ago in terms of how we organize our curricula and the exposures our students and residents get. Have you thought about what we can do to press for changes both in LCME and ACGME standards and licensing requirements so that we train future generations to actually be able to care for the dominant patient population that they will serve?
Right. So when you approach those organizations, they currently see aging as sort of a special population situation, even as they acknowledge childhood and adulthood. So what I think we need to do is frame it as you are already doing this, and then populate their approach with solid data on outcomes in older adults and gaps in training, and present it to them. I know some people are talking about this, and I think it also will need to include our colleagues from other specialties so that it doesn't just feel like a special interest. We like to think of ourselves as advocating for the people we serve, but we will be seen as a special interest. But I know, and this is more common among surgeons, but all the people with the, neurosurgery, orthopedics, all those partnerships have really shown the differences that can be made. And other specialties, from anesthesia to family medicine, also already have some of this focus. So I think we need to harness a group of professionals from across specialties and present a solid evidence-based case. If your you base the past pattern on this age period and these assumptions, and here's how it rolls out. Now, here's the reality on the ground, and this is what a new approach would look like. But I think it has to be a really large, diverse national group and a really solid argument, essentially, a white paper or something, and then an audience in which that the case is made for major transformation. And then, it'll still take 5 or 10 years. But I think we have all the evidence we need. We just may not have compiled it in the right way. And I also think we show change from within. Some of this stuff about really starting to train our own trainees to care for all older adults, whether healthy or sick, whether frail or hale, whether in their late 60s or late 90s. We have to clean house before we can ask things of others.
Well, anytime you want to start, advocating, I'm down to go with you. So.
Oh, that sounds great. I'm signing you up. Thank you.
Just a couple more, Louise. I'm going to try and lump a couple of thoughts together. And one of the questions that comes up is this issue of both internal and external ageism. And what do we need to do in order to change the narrative, both for those, as you said, the others, the 65 and over, and those who are in that other category and may be saying, I'm, in my 80s, and why should I bother with this, or why should I bother with that? Why should I get this invasive test, and why should I not get this invasive test?
Yeah, I've actually started teaching the ageism stuff to my patients, so discussing it with them. I also, this is anecdotal, but in speaking to people at our sort of Latinx Health Center and elsewhere, our Center for Vulnerable Populations, it appears to hold. There are some cultural, differences in age, and how age is perceived. So sometimes younger people from some backgrounds will say, I'm old, there's nothing more to do, and from others, I actually had this in clinic 2 weeks ago where I had a 71-year-old tell me she was old, so it didn't really matter. And then I had a 94-year-old tell me that it was unacceptable that she was having more trouble walking, and that I needed to fix that. So we need to give everybody more agency about their health. But I think addressing it head on makes a big difference, to talk about isms and prejudice against the self and how it affects health. But starting there sounds preachy. So I think I start where I always do is, tell me about you, and tell me, your best case scenario. Like, what would you hope for? And sometimes people hope for something too little, and then you can say, dream bigger. But you have to get to know what a person's priorities are and what it is they'd want to do, because I still find myself regularly surprised by what really matters. And I think when it comes to the 4 M's, it's that what matters, and that what matters should guide what happens. But if most people, and there's a great Cesar Chavez quote I'm not going to do justice to, but it's something about, in order to make change, you need first the imagination to imagine it's possible, and secondly, perseverance. So some of it is setting up a conversation in which people can begin to imagine a future more in line with what they would hope for. And then the second is giving them the support to persevere through making that happen, because some of it takes work. Like, yes, you can walk well again. You're going to have to work really hard to do that. But is it doable? Without a doubt.
I am conscious of the hour, so I'm going to give the last question to our former chair and my former boss, Al Su, who asked whether the satisfaction by age and happiness data that you presented earlier, how much of that is age and how much of that could be a cohort effect or generational? And as the father of a millennial and as a baby boomer, is my kid going to be as happy as I am when he gets to my age?
Such a great question. I think we don't yet know the answer. I hope it holds in many ways. On the other hand, we need to do something about the miseries of middle age in that case, I suppose. We've seen it happen through three different cohorts. So, silent, great, and boomers so far looking good for it. But there have been significant shifts since then. So I think we won't know until we get closer still. It would be interesting to look at millennials in terms of the first part of that curve, the earlier lift. Did they have that lift and are they coming down? That might give us some clue into the future. There's always a lag between, cultural changes and what we're addressing. I would hope it would be true. And I actually think we can make it more true by addressing some of the, tech and other induced miseries of millennials and younger generations. I mean, the fact that people, we talk about how old age must be miserable because of all the bodily changes, but in fact, it's the people with the best bodies of all that are most miserable right now. So it's more complicated than that. And maybe we could be, instead of responding retroactively, we could be thinking about how to improve their mental health now so that when they get there, they can take advantage of some of the many benefits of old age, which include, working less and having already raised your children and all those great things that seem to lead to happiness, and having a little more time to do the things that you've always wanted to do. So I think we can actually stack the deck in how we create age-friendly and when I say age-friendly, yes, my focus has been older adults, but I think we need to be friendly to all ages. The isolation of young people is at least as appalling as the isolation of people in long-term care.
Thank you, Louise. And on behalf of all of us, thank you so much for spending the time with us today. I know there are many questions that still didn't get answered. However, many of those can be found, answers to that, in Dr. Aronson's book, which is, Katie, available at your local independent bookstore. And if you don't know where your local independent bookstore is, you can find it at this link, which is in the chat. And I would encourage all to, if you haven't read it, to pick up a copy and read it. And the last piece that I would say is that if you liked what you heard today and you like to support both the department and the Hertzberg Institute, there's a way that you can do that. And that is also, that link is also in the chat. And please feel free to join us in our work together. Again, my thanks to Dr. Aronson for a really thought-provoking and wonderful West lecture. And of course, our thanks to Susie West and her family for making this all possible. I wish everybody a really safe and good evening, and hope to see you again next year for the 25th West lecture, which hopefully will be both in person and in virtual. So thank you all very much and have a quiet night.